everybody. My name is Timmy Frawley. I'm a member of the UCD Neurodiversity Working Group. And I'm joined here this evening by colleagues, Mr. Ken Kilbride and Miss Beth Kilkenny, but also our special guest for the evening, following on from our very useful talk last month with Davida and colleagues. I'm delighted to be joined by Dr. Seonaid Anderson. And Seonaid is a chartered research psychologist and freelance neurodiversity consultant with many years' experience in neurodevelopmental disorders. For 8 years, she was the manager at Tourette's Action in the UK and has now set up her own business, Neurodiverse.org, with clients including Tourette Association America and the American Society for Epilepsy. Seonaid created the Behavioral Therapy for Tics Institute, which offers online behavioral therapy training for tics and other events for clinicians and therapists. She contributed to the updated European clinical guidelines for the treatment of Tourette syndrome and writes for and creates podcasts for the Association for Child and Adolescent Mental Health. Seonaid has also written publications on the subject of Tourette syndrome, so plenty of opportunities, I think, to follow up with her work in addition to this evening's talk. Seonaid is a board member of the Belgian Tourette Syndrome Patient Association and is a member of the organising committee for Tic and Tourette syndrome advocacy groups across Europe. So it's really wonderful that you can join us, Seonaid, for this evening's masterclass. And just, of course, to remind everybody gathered here this evening, we record the talks, and anybody who's registered, that is, who's here, will receive a recording of the talk when it's finished. So no need to worry too much about taking notes, because you will get a copy of the recording. We'd encourage you to pop any questions into the Q&A function, and after the talk, it'll be really good to hear Seonaid's views and ideas. We'll try to get through as many questions as we can. So without further ado, I'll hand over to Seonaid. Thank you so much for joining us this evening.
Thank you so much. What a lovely welcome. That's really nice. I'm hoping that you can see my screen and my slide now, the first slide. Yes, thank you so much for inviting me here. I know that there's going to be a lot of experience in the audience as well, and lots of clinicians and researchers, as well as maybe patients in the audience as well. So thank you so much for having me. I will just say just one slight correction to make. I wasn't the manager of Tourette's Action, but I was the research manager, and they just recently have a new CEO in place, Emma McNally, but I will be talking about Tourette's Action a little bit, and that's a great patient association for everyone to be sort of signposted towards. And so I'm delighted to talk to you this evening about tics and tic disorders. And I've entitled the talk Part of the Neurodiverse Iceberg. And I hope that you'll agree with me that it's an important part of an important kind of neurodiverse condition. And I'm hoping that we can learn together some things about tics as we go along. So thank you again for inviting me today. So I'm going to just briefly go through what are tics and what are tic disorders, including Tourette syndrome. What are some of the signs and symptoms that might be discussed, what the causes might be very briefly, and talking about co-occurring features and conditions. And there's a great deal of overlap, as we'll find out as well. So just also to be clear, I'm not a medical doctor, I'm not a therapist either, so I don't deliver the behavioural therapy, but I am, as Timmy said, a research psychologist. So I feel like I have a foot in each of these different camps. So the patient advocacy camp, as well as clinicians and researchers as well. And I hope that I can link up people together really to benefit people with Tourette syndrome And when I say patients or people with Tourette syndrome, I kind of use those terms interchangeably as well. I hope that's okay with everybody this evening. So there's some misunderstandings around Tourette syndrome, that's for sure. We hear that a lot, and we probably all have a view as to what Tourette syndrome might be. And I'm here to hopefully increase your knowledge a bit about tics and Tourette syndrome. And as I talk through some of the slides that I've got today, you might start to recognize tics, either maybe in yourself or when you were a child, or maybe in your own children, or children that you might work with, etc., etc. And that's fine, because my main message is that there are actually tics everywhere, far more than you might first have thought if you don't know too much about this area. And so there are some myths around this. Often people associate Tourette syndrome with swearing, that it's all about swearing, that you have to swear, and that is part of the condition. Also, people believe that it's very severe, so it's people making very loud noises and very large gestures, etc. And also that it's very rare. And another misunderstanding about it is that it's often people behaving badly. It's their behavior is what's causing the things that we see. And so just to go through each of these, the swearing tic, which is also known as coprolalia, in fact, researchers believe it only occurs in around 10 to 15 to 20% of people with Tourette syndrome. So much, much lower than perhaps TV and films might have us think, because it's often people at the quite severe end of the spectrum of Tourette syndrome that are represented on television. And there have been arguments by different parts of the patient community as to whether to change the name Tourette syndrome, because there seems to be a lot of stigma attached to it, and also lots of these misunderstandings around it. And so it's been put forward as perhaps we should be calling it tic spectrum disorder instead. But as we'll see as we go through, tics can be small. They are repetitive sounds and movements, but they can be quite small for somebody to actually get a diagnosis of Tourette syndrome. In terms of prevalence, this is one I like to get in early when speaking with people, because it's got the same, Tourette syndrome has the same prevalence as autism, we believe, at 1%. So that's around 1 in 100 school children. So that often takes people by surprise. And you can see that, in fact, it's not rare, not as previously thought. And tic disorders are more common in children than in adults, and in boys than in girls, and also in special education populations as well. And in regards to people just behaving badly or saying rude things, and this is in fact a neurological condition, and it's involuntary. They're not just saying what's in their heads. And there's a fantastic Tourette syndrome advocate called Jess Tom, who also goes by the name of Tourette's Hero. And she has many, many tics, and one of her tics is that she says the word biscuit. And very often when I've seen her in videos and she'll say, I'm not thinking about biscuits this much. This is not just a thought that's leaving my head. It's different. So what we do know about Tourette syndrome is that it does interfere. It does have the capacity to interfere with major domains of people's daily lives. So both children and adults in terms of their school, work, social relationships, etc. And one of the main messages I would really like to get across is that actually tics are far more common. So they're very common. There are many different types of tics. It basically can be anything that involves a muscle group anywhere in the body. And they're often misunderstood. So if you see somebody ticking in the street or on public transport, it might be misinterpreted. And as I said, some tics are barely noticeable, very small indeed. And one of the most common one is a blinking tic. Other tics can be distressing, and they can cause social isolation. They can cause embarrassment and stigma and result in low self-esteem. There are often reports of people finding their tics very painful indeed. But as children grow, it usually starts in childhood, around the age of 7, you know, give or take some years. And as children grow into adulthood, about a third of cases, the tics will reduce, and the researchers are not quite sure why this is happening. But they think it might be that people have better control with age to manage their tics, or it may be that actually the tics themselves just subside. But the adults that are left with Tourette syndrome will have Tourette syndrome for the rest of their life. It will be lifelong. And it may be that they have a more severe form of Tourette syndrome than the people whose tics kind of resolve themselves. So we'll quickly go through what are tic disorders, and Tourette syndrome is a tic disorder, one of a few. We know it's a neurological disorder, therefore it's not learned, but it is influenced by people's surroundings. And we've mentioned it's more common in males. And in regards to intelligence, there's no cognitive deficit. So people have normal intelligence as well as having tics, but their learning can be challenged. And we can talk a bit about that later. Also, tics wax and wane, so they come and go in intensity and frequency. They can change over time. Somebody may have a shoulder tic that goes on for a while, and then another tic comes along. We do know that they increase with stress, but that can be around exams or driving tests or the transition to secondary school. All of those things can cause an increase in stress. But also with positive excitement as well. So maybe around birthdays and Christmas, going to Disneyland, etc., you might also see an increase in tics around those times too. A lot of people with tics describe something called a premonitory urge, and that's a way of saying that there's a physical sensation that they feel in their body before their tic arrives. So they can feel a build-up of pressure, and it's described by people with tics in different ways. So maybe an itching or a rising uncomfortable feeling or a kind of electricity. And this often occurs before a tic. So somebody can feel this happening, and then the tic happens, and then this urge decreases once the tic has been performed. The tics are, to a certain extent, for some people, I would say suppressible, but I find the word suppression a bit of a loaded term, so I prefer to say manageable. So it might be that some people, for some of their time, can manage their tics. They can control it for a certain amount of time, but it may be that actually it builds up and they have to let the tic out. That's an important point about tics. Another important point about tics is that they're suggestible. They can be suggestible. So a bit like if I was to yawn just now, and you all watch me yawning, you might also then yawn. We have mirror neurons in our brain that causes that kind of response. And so too with tics. If I have a tic and you also have tics, you may for a while pick up some of my tics. And we find this from running support groups, that people come along and for a short while, including maybe a short while after the support group meeting, they may pick up tics from other people, but they usually subside and disappear again. And the people that come to the support group say that it's definitely worth coming, despite the fact that they might tic a bit more or have a few new tics, which then disappear afterwards. So some of the aspects about tics that you might not be aware of. And this is the man, Georges Gilles de la Tourette, who was a French neurologist in the 1800s in Paris, who the disorder was named after. You're very welcome to go and read his autobiography, or an autobiography that was made, a book written about his life, to find out more about him. A very interesting character indeed. So as I've said, tics are common. They usually appear around 5 to 7 years of age. They're not usually serious, and they, as I've said, usually improve over time, but they can be frustrating and interfere with activities. And depending on what types of tics and how long the tics have been going on for, that will play a part in whether somebody actually gets a diagnosis of a tic disorder. And tics themselves, what are they? So it's a sudden, rapid, motor movement or vocalization. So a movement or a noise that somebody makes. And they can be categorized into simple tics and complex tics. I've mentioned that in some cases they can be manageable, but generally they're felt to be involuntary. The person has little control over them. And tics can occur in any part of the body. Research has found that they occur during sleep. And I said they get worse during times of stress or excitement. And this table shows some of the examples of common motor and vocal tics that occur. And so we've got simple and complex down the side, and then motor and vocal tics across the top. So we can see one of the first ones that often starts is eye blinking. Ones around the face, head, and neck are quite common to start off with. And they can be eye blinking, eye rolling, grimacing, so pulling faces, and moving down the body. And then there can be more complex motor tics, so they could be jumping or twirling. They could be making obscene movements or gestures, or it could be repeating other people's gestures. And then the vocal tics can be simple in regards to the type of tic that they are. It can be whistling, throat clearing, various animal noises, but sniffing, coughing, etc. And then the complex vocal tics are where people might actually say words or sentences as well. And that's where the coprolalia, the involuntary swearing, is found. So just to quickly give you an update on the COVID situation, I know it feels a little bit like we're coming out of COVID now and the mask requirement perhaps is being removed, but COVID has been a difficult time for many, many people. But one aspect that you might not be aware of is that for people with Tourette's syndrome, we noticed that there was a really large increase in people's tics, in the number of tics and the intensity, and suggestible tics. So this is maybe somebody thinking, if they're on public transport, for example, and crowded together with masks on, etc., during a COVID situation, they might find that actually the tics that want to come out are the coughing and the sniffing tics, and that can make it, or it has made it difficult for people during the COVID situation, because people have thought these might be COVID symptoms, but actually they might have been tics. And there's lots of stigma and misunderstanding around that. So support associations such as Tourette's Action and Tourette's Association America have produced some cards which have been very helpful in terms of being able to show to people on public transport and give them a bit of an explanation in terms of why somebody is acting in the way that they are on public transport. And another aspect which I'm probably not going to get into because I probably don't have time, but there has been in the media a reporting of a sudden onset of tics during the pandemic. And there were some research papers or some clinicians' observations that were published during the pandemic, which were then put in journal publications, but then the media picked up on it as well, and there was a bit of a sort of slight hysteria around, whether lots of young girls were now picking up tics from social media platforms such as TikTok. But as we've moved on from that, we know it's a much more complicated situation, in fact. If we have time, I can certainly answer questions about that, but I'll probably leave that at the moment. There will be lots of signposting at the end I can give as well if you're interested in that particular aspect. But that's really related to functional neurological disorder rather than tics and Tourette's syndrome, which is a different kind of condition. But I just thought I'd mention that. So going back to the tic disorders, I'm not going to spend too much time here. There are different ones, including transient tic disorder, chronic tic disorder, and we see Tourette's syndrome. And for Tourette's syndrome to be diagnosed, the patient has multiple motor and one or more vocal tics, which have persisted for more than 1 year since the time of first tic onset. So you may not know that you needed to know all of that about tics, but basically there are many more tics than we might first have thought. So if we think about all of those tic disorders together, the transient tics, the chronic tics and the Tourette syndrome, as well as sort of childhood tics that might sort of come and then disappear. There are, going to be far more tics than we might first really have thought about. But what we're saying about tics applies to all of these different tic disorders. So the clinical pathways are the same. So when somebody gets diagnosed and treated, it will be the same kind of pathway, and they may be treated with the same kind of medications and behavioral therapy as well. So just to show a little bit of publicity around Tourette's, that it's more common than having green eyes, that it's not about defiance, and in fact, around 50% of children with Tourette syndrome or a tic disorder go undiagnosed, according to the Tourette Association of America. And because it starts off often as a kind of nose scrunch or a sniff or with an eye blink, people can end up going down the road of going to ear, nose and throat clinics, etc., because nobody's recognized that this isn't actually an allergy or a lingering cold. These are actually tics that are being expressed. So I think we've already covered most of these things. I probably won't talk about behavioral therapy and medication, that could be for another day. But what we definitely know is that there's lots of crossover with other conditions, and that's where perhaps this audience will be most interested in terms of neurodiversity. About 80% of people with Tourette syndrome will have co-occurring conditions, so conditions that come along as well as having tics and Tourette syndrome. And these are some of the common ones. So autism, attention deficit hyperactivity disorder, OCD, anxiety, depression, learning difficulties, etc., and also sensory sensitivities as well. This is the sort of famous iceberg diagram that's been shown in lots of different situations. But basically, the main point is that the vocal and the motor tics are really just the tip of the iceberg. These might be the things that we see and hear, but actually, all of these other things that can come with the tics can often be the most difficult and challenging for the person with Tourette syndrome themselves. And of course, this lovely Venn diagram that I'm sure you're all used to seeing, and it's great to have tics also in that overlay as well, really showing the interplay between those different conditions. The things we haven't spoken about are anger issues and sleep issues, and anxiety and depression as well. And some work from the Karolinska Institute in Sweden found that people with Tourette syndrome had a higher suicide rate compared to the rest of the population there. So we do have research now to back up the fact that, Tourette syndrome is not perhaps a funny disorder as people might have thought of before, and this actually requires attention and sensitivity and some investment in terms of treatment and management and looking after this patient community. This is very small, unfortunately, but just basically how some of these challenges might create issues at school. So there might be specific difficulties with reading, writing, maths. We know that executive functioning is often an issue. So somebody might be reluctant to read aloud or answer questions or ask for help. There can be social and emotional challenges. So maybe it's difficult to make friends. You might be excluded and bullied, and therefore feel sad and upset and anxious and angry as well, and maybe have anxiety about ticking in front of peers too. And there can be challenges to learning in terms of difficulty with motor skills. So if you're ticking so much that your handwriting is affected, or your fine motor skills, or you're blinking so much that you can't read the board at the front of the classroom, then that can have an effect as well. And for those people that are actively trying to control their tics, it can take a lot of effort to concentrate and actually not tic. And therefore your concentration is perhaps taken away from the lesson, the things that you're trying to learn, or the instructions that are being given, and somebody can fall behind. Teachers making mistaking tics for rude behaviours. Now this might happen in a situation where a teacher doesn't know the child very well and may not know that they have tics, but a common one that often comes up is an eye rolling tic. So somebody's rolling their eyes, but that, of course, could be misinterpreted by somebody as sort of cheeky behaviour, for example. And of course, in the classroom, children with Tourette syndrome are going to probably feel tiredness and pain. There are often sleep issues, so they may have low motivation. They may be taking medication for their tics, and some of the side effects are that it can make children feel very tired and quite lethargic, and all of these things can affect their work and their learning. I'm going to move on from managing tics to talking about trying to inspire young people with Tourette syndrome. There are more and more celebrities coming forward to say that they have Tourette syndrome. One of the best known is Billie Eilish, which many of you might know. She's got Tourette syndrome and incredibly successful in her sphere. There's another woman who is an internet celebrity called Lily Pons. She also, and she posts videos about her Tourette syndrome and other conditions that she has. And we've also got Casper Lee in the UK. He's a kind of YouTuber and influencer, if you will. So these are great people to show to young people, especially at the point of diagnosis where they might feel, oh gosh, I've just been given this label of Tourette syndrome. You know, what does that mean? But also there are many, many people out there with Tourette syndrome who are not celebrities, but they might be a teacher or a musician, etc., who are living with Tourette's and getting on very well. They have a career, they have a family, etc. And it's important that we can sort of show that to people, especially to young people when they're at that point of diagnosis. So I'm going to move through the sudden onset because I think it might be, we can certainly talk about it, but we might run out of time otherwise. And of course, people are welcome to have the slides afterwards to this presentation. I would certainly direct people towards Tourette's Action and Tourette Association of America. It shouldn't say TICS there, but it's Tourette's Association of America. And of course, the OCD, ADHD Foundation, ADHD Ireland. And in the case of this functional neurological disorder, which I spoke about as well, there's a couple of great, there's a great website called neurosymptoms.org. And just recently, a couple of clinicians from Great Ormond Street Hospital had a article in TES, and that was looking at how schools can support teenage girls with tics, these sort of functional neurological disorder tics, as it were. So people are very welcome to contact me, look at the website. You know, my sort of specialism is in tics and Tourette's, and I'm on different social media channels. It's always nice to hear from people, and you know, be welcome to read my blog, etc., on the website. And I often like to finish with this little cartoon. I'm not an artist by any means, at all, but I quite like this. It's two researchers, scientists in a laboratory, and one saying to the other, I've just invented a new drug for Tourette syndrome. And the other researcher says, will it stop people with Tourette syndrome having tics? And the other researcher says, no, it's an acceptance pill for everyone else. So I quite like that, the kind of statement there that actually it's really important about accepting people and their differences and the challenges that they're facing. And there's so many people with Tourette syndrome that are fantastic patient advocates doing so much work. You know, I don't have tics or Tourette's myself, but you know, there are many, many people out there doing fantastic awareness raising, you know, in the UK and across the world, really. So thank you so much for having me and listening to the presentation. I hope if you have any questions or comments, you're very welcome to ask them now or afterwards. It's no problem for me. Thanks, Jimmy.
So thank you very much, Seonaid. It will be no surprise to you to hear that that's, I must say, the best talk on tics and Tourette syndrome that I've heard. And I'm going to maybe ask you a little bit on the behavioral management, but also on the medication management. I'd love to hear your views on that. please?
Oh, that's really kind. Yes, I mean, I didn't touch on the behavioural management at all. So yes, there are various forms of medications that people can take to try and reduce their tics. I think it's very tricky in terms of getting the right kind of medication for the person. And also with the waxing and the waning that occurs, it can be quite difficult to see whether a medication is being effective or not. I think one of the things that faces a lot of people, especially parents, is that they don't really want to put their children on strong antipsychotic medication, because that's the kind of medication that it would involve. But I think it's really important to speak to your healthcare provider about that and talk about your concerns in terms of medication. And it's going to be something that's very closely monitored, and perhaps a very light dose would be started off, etc. So I think it's really important to speak to your healthcare provider. And of course, if there are issues, say, for example, your child has ADHD and tics, if it's the ADHD that's actually causing most of the issues and challenges on a day-to-day basis, then it might be helpful to sort of treat that first. And that, again, would be a really important conversation to have with your clinician, with your healthcare professional. I think lots of people would like the choice of medication or behavioural therapy. And often it's a challenge because there aren't enough trained therapists either. I think I mentioned the side effects from medication. That can be, an unpleasant part of taking medications as well. So the behavioural therapy really is where somebody goes along, and probably there are lots of people with tics that already do this, but there are different forms of behavioural therapy where the therapist will work with the young person, first of all, or adult. It can be for anyone. And find out, first of all, really, are the tics bothering themselves? And if they're not, that's fine. We're not going to do behavioural therapy on somebody that, is actually fine and really adjusted with their tics. So that would be one of the first things to talk about. But if the tics are bothering the person, they'd like to try and have a bit more control, maybe there's pain associated with the tics, then that's something that the therapist can work with with the young person or the adult in the therapy sessions. And of course, homework is a really important part of that. So working in the therapy sessions to see perhaps how long you can last without ticking, or perhaps doing another movement or holding yourself in a certain way so that the tic doesn't happen. There are different types of behavioural therapy in that way, and practicing that and doing homework outside of the session is really important. But a large part of behavioural therapy, of course, is about accepting the tics and actually talking to the young person. It might be the first time that anyone's really acknowledged their tic, and it's really wonderful to see. It doesn't work for everybody, of course, and again, if you've met one person with Tourette syndrome, you've met one person with Tourette syndrome, because everybody is different. But I think it feels like there's quite a push from the patient community in terms of trying to get more access to behavioural therapy. And one of the benefits, the only benefit from the pandemic, is that telemedicine seems to have been a bit more widely accepted, and actually people can have appointments and therapy online. So no matter where they are, if there's no trained therapist in their area, they should hopefully still be able to access it from a distance. And so I feel quite passionately about behavioural therapy, and that's why I set up the Behavioural Therapy for Tics Institute. And so there are 2 trainers and myself, and we've trained so far this year, I think we had 70 clinicians trained, some from Ireland, but Wales and England, Scotland, and around the world, because we really want to try and address that gap where there are not enough trained therapists. And we really hope that that's something that's going to make a big difference to, directly to the patients. And as well as the training, we also offer masterclasses where we take a deep dive into a particular subject. So maybe looking at somebody, how do you deliver the therapy if somebody has learning difficulties or challenges? And we also have clinical consultation sessions every month. So that's where clinicians can come and talk about perhaps challenging cases or how they might want to adapt the therapy, etc. So I think that whole package is really important for the clinicians so that we can really support them. We know they're under a huge amount of pressure, and so the more that we can do, the better. And we also have webinars for parents and teachers and non-clinicians who can come and find out, you know, what is behavioural therapy, what can it do, etc. Because you know, information is really important. People might not choose behavioural therapy, but at least they can understand a bit more about it. But there you go. I've gone off blethering. I'll pause for breath.
Well, do pause for breath, Seonaid. I'm glad to see you with a glass of water there. Prior to handing over to Beth and Ken, who have the questions, and thanks to everybody for asking questions. We're going to get through those now. Just a final concluding question from me. I mean, I loved your slide on the iceberg, and I think it's so important, you know, to look at what else is happening for a person, be they other maybe co-occurring conditions or be they the other social factors that you mentioned, such as exclusion, bullying, all of these things. Just on the behavioural therapy again, may I finally ask, is there any particular school of behavioural therapy, or perhaps is there any accrediting body which you would espouse or recommend?
That's a really good question. So there are different ones, different sort of types of therapy. So there's exposure and response prevention therapy, and there's habit reversal therapy. And in the States, they're very keen on something called CBITS, which is the comprehensive, now I'm going to get it wrong, intervention behavioral therapy. And that's basically one of those therapies together with relaxation strategies, etc. So it's kind of like a package. So it's still the same kinds of therapy being used. And one of the therapies is where you sit. You can work on all of the tics together at the one time, and you sit with that really building unpleasant urge for as long as you can, and you can do this in a timed way with the clinician in the therapy sessions, and they'll see how long you can go, and the person should be able to go longer and longer and longer between ticking, and getting used to that unpleasant urge, feeling that sensation. And the other one that I spoke about was where the person will sort of do, you know, if they have a shoulder shrug or something, then together with the clinician, they'll work on doing a sort of opposing and competing response that's not too socially noticeable. It can't be something that's, you know, going to be sort of bigger and more attention forming than the actual tic. So they can work on that with the clinician as well. But I think it's very helpful also for individual painful tics as well, which can be very distressing for the person and the parents and the people around the person as well. So pain is something I think that a lot of people with tics would say that it's not really considered, but it's really something that impacts on their life.
Thank you for highlighting that as well. I must say it's something which I would have overlooked. So thank you. I'll hand over to Beth and Ken.
Okay, good afternoon, Seonaid, and thanks very much. And I say thanks for the presentation. It was, very insightful and interesting, particularly if you've not seen anything much about Tourette's or Tourette syndrome in the past. Forgive me for asking the first question. You may not know the answer to this one, but we'll expand on it. So Carolyn was asking, in Canada, you can't get a psychologist or psychiatrist without a general doctor's reference. How do I overcome this? Now, accepting you may not know how you get a diagnosis in Canada, but what's the process generally if you have a child or an adult with Tourette syndrome to get a diagnosis?
That's a really great question. I actually made a video about this. I didn't include the link, but I can certainly send it to you afterwards. It's about clinical pathways themselves. So how it tends to work in the UK is, of course, you visit the general doctor, first of all, the GP. And what might happen at that point is the GP may send you away saying, okay, well, for if the tics are not too bothersome, then we'll have a kind of period of watchful waiting to see if the tics go on and, you know, if they're really impacting on the person's life. So they might do that, but if parents and the patient are saying, well, actually they've had tics for years and years, or the tics are currently really very difficult for day-to-day living, then the GP might make a referral onto, and this is where it gets complicated for Tourette syndrome. It might be a variety of healthcare professionals. So all the different types of people that somebody with Tourette syndrome might see, you start off with a GP, you might get referred to pediatrics or pediatrician, and you might end up being referred to CAMS, Child and Adolescent Mental Health Services, and you may get referred to a neurologist also who might make the diagnosis. And in Europe, it's the neurologist that makes the diagnosis. And then you might kind of bounce back between those different people. And again, it seems to depend on the level of knowledge that each of those professionals have, and also if there is a kind of clinical pathway set up already in that area. So if there's a tic specialist centre, there's 2 in London, there's 1 in Nottingham, for example, and then probably the doctors and paediatricians, etc., in those areas know that, all right, I recognise tics, and will probably refer them to those specialist centres. But they can be, and probably there's an argument that they should be diagnosed locally, that actually right on the ground level, that GPs and paediatricians, etc., should be able to diagnose this straight away, rather than sending them on to sort of tertiary levels of care, where actually, unless the situation is particularly complex, that, you know, sort of very sort of basic tics and tic disorders should probably be diagnosed sort of by GPs, by paediatricians, by that kind of healthcare professional. But we've also heard from across the UK that sometimes CAMS say, well, we're not going to treat or accept you into the clinic because it's not a mental health disorder. But of course, you know, I would argue that if healthcare professionals are seeing children already with ADHD and OCD, then a really high number of those children will also have tics as well. Yeah. And it may just be, you know, if you're treating somebody for ADHD, but you say, oh, I noticed that you're ticking. I noticed you have an eye blink. Are you aware of that? And how do you feel? And, you know, just actually broaching the subject with them in a kind and compassionate way. And then you can always sort of say, oh, well, if it's not bothering you, that's great. But if you ever need, or you feel that you would like some therapy to try and control your tics a little bit more, you know that we're here for you, etc. So I think that really early kind of psychoeducation would be really super helpful for so many young people.
Okay, thanks for that. If I may, just before I, Rob, stick another question in just before I hand over to Beth there. So a very quick question that came in just at 5:30. Is there any correlation, either high or low, with Tourette's syndrome?
Sorry, say again.
Was there any correlation with IQ?
Oh, IQ, sorry. No, I think that on one of my slides, I was saying that there doesn't seem to be any correlation with, you know, people with Tourette syndrome have a kind of normal intelligence, you know, just with the general population, there's no sort of cognitive deficit there. But what might happen is that they might be more susceptible to having another learning difficulty, such as dyspraxia or dyslexia, etc. So there might be a slightly higher prevalence in that population. But it doesn't go hand in hand, and it's certainly not part of the diagnostic classification at all.
Thanks for that.
Okay, thanks, Ken. So there's a question here actually that's just come in, and it's what is the difference between stimming in autism and ticking? Seems like the two can overlap, particularly given the co-occurrences of TS and ASD that you've mentioned.
That's a good question. Yeah. So, I mean, I think the thing is that they're both movements, aren't they? Stimming and ticking, they're both kinds of movements. But I think what is behind them is quite different. Now, again, where there's an overlap, where somebody does have autism and tics, that's going to be more complicated, perhaps, to tease apart, of course, for the clinician. But I think there's a different kind of quality behind each of those things. So stimming is, I understand, is something that's generally something pleasurable or sort of soothing for the person who's doing that. Whereas tics are not, that's not the case with tics, especially when we think about the pain and the issues and the kind of social embarrassment as well of feeling uncomfortable, not wanting to do that movement or sound. So I think they're coming from different, quite different sort of areas, but I agree it would be really quite complicated if there's an overlay of different symptoms in the one patient, of course. That would be difficult. And of course, stimming, as far as we know, there's no premonitory urge to stimming. Tics and the urge are quite, closely related. And so there are differences there, although they are both movements, there are differences between them as well.
Great, thank you. Do you want to go, Ken?
Yeah, no, there's a question in from Alison. I think there's two questions within this. And she's saying, is there any way workplaces can become more welcoming for people with tics? And how do you make the workplace more accessible? So that'll be the first question. That's the direct one. But within that, there's the question around stigma and self-esteem. And my view, and it's my view, is that it's just about okay now to go into the workplace and say you have autism and dyslexia. But getting there with ADHD, I don't think there's anybody going into any workplace saying I have Tourette syndrome. So what do you think is the public perception of the condition? So how do you make it better in the workplace, and what's the public perception?
They're great questions. No, I think you're right. I think there's a lot of shame and stigma around Tourette syndrome as well. And when you say, I have Tourette syndrome, or somebody says that, I think there are assumptions and those myths and understandings kind of pop into people's heads, whether they're employers or the general public, and probably going, this is somebody that's about to, swear and, use foul language, etc. So I think there can be real difficulties in terms of workplaces, especially those ones that are maybe customer facing, or if you're working in a school or with different populations of people that it's part of your job to actually interact with groups of people. So there has been a teacher on television who had coprolalia and had quite severe Tourette's, and she was working in a school, Natalie Davidson. And I think it's really down to the person and the employer to try to make it work. And, we know that there are so many, when we look at all the sort of neurodiverse conditions, whether it's ADHD, tics, etc., that they are everywhere, and to actually push against that and discriminate against people or not offer them employment, etc., is a bad thing. We should accept and embrace neurodiversity in general. I think people with Tourette syndrome, they have, we try and say, look, it is recognized as a disability. And so therefore, there are certain sort of regulations and protections that come with that. So somebody can't be fired because of their Tourette syndrome, etc. But that's certainly not the case around the world. In New Zealand, it is not recognised as a disability. And the New Zealand Patient Association is trying to change that. So I think probably for somebody going for a job interview that has tics, it's quite difficult to hide something like that. Again, the person might be able to control during the interview itself, but it really depends on the types of tics that they have. And I would encourage people to get in touch with Tourette's Action to talk about how employers can be more welcoming to people with tics. And actually, I think doing webinars and things like this hopefully reach a lot of people as well. And I think there may be people in the audience also that might go away going, okay, tics, yes, I can see more of them. I remember when I was working at Great Ormond Street Hospital, I thought I hadn't met anybody with tics before, and I went to help with the support groups one evening. And on the public transport afterwards, since then, it was really a bit of a turning point. I can see tics everywhere, and probably Uncle John has, a sniffing and a blinking and maybe a neck tic that we go, well, that's just Uncle John. But he probably could get the diagnosis of Tourette syndrome. So there's this wide spectrum, and I think jumping to assumptions that somebody's going to not be a suitable employee, they're going to shout and swear and be difficult, that's not the case. There's lots of examples of people who are fantastic, fantastically talented, musicians, teachers, all sorts of examples from the patient community of people who have Tourette's that, you know, people should be given a chance and absolutely show, you know, show that they're open to welcoming their doors to neurodiverse communities, of course. And with that overlap between the conditions, you know, it's great that this neurodiversity movement has started, because then we can all sort of come together and our voice is a bit louder that way.
Thanks. Just for another quick question before I hand back to Beth, very short question again. Does yoga help minimize ticking?
Well, it might do. It might do for an individual. I think there are relaxation techniques that people can find, and again, it's really individual, isn't it? People might find useful. There's, you know, 5-finger breathing. There's diaphragmatic breathing. There's a guided relaxation on the Tourette's Action website that I helped create, so people can sort of still kind of have a relaxation while they're ticking. I think there's lots of things that individuals can do that they find helpful themselves, but we can certainly suggest or share ideas, but I think it's up to the person themselves to find out what works for them. It might be listening to music, it could be swimming, quite often something that takes up somebody's concentration, like drumming or music, singing, for example. The person doing it often will report that their tics actually get less while they're really absorbed and engaged in that particular activity. But then at the same time, you might watch your child on the PlayStation absolutely ticking away while they're, you know, having lots of visual stimulation and also really excited, so their tics might increase. But, you know, that's okay too, you know, as long as if they're enjoying themselves and they're kind of relaxing in that moment. But yoga, relaxation, I think it's all there if people want to try it and see if it helps. And we've heard that it does for some people. So yeah, it's can be part of the toolbox.
Thanks for that.
Thank you. So this comment and question has just come in, and I suppose it's about kind of managing Tourette's kind of within the family dynamic and the family environment. So Valerie says her son is 14 and has Tourette's. He has huge rages that come from small conflicts. He will cry and curse and punch the microwave. He has a punching tic. He'll often hurt himself, and there's nothing personal in it. And once he calms down, he goes back to his normal self. It's hard to know how to manage his behavior. It can be intimidating and aggressive. And Valerie says, there's also the teen in there. So myself and my husband have a different view. He thinks I let him away with it. I think he loses all emotional regulation. Have you any tips on kind of how to manage that kind of situation?
Oh gosh, yeah. I mean, I'll definitely send along some anger resources afterwards. I haven't put them on my slides, but I think that's a really important point. It's definitely something that people talk about as being a problem, and you can imagine why. You know, again, you mentioned emotional regulation, and also the frustration that must build from, you know, having tics and not being able to control it, and you've had a really frustrating, tiring day at school, and perhaps been trying to control your tics all day, and then coming home there's a kind of release because you're in this sort of safe environment, etc. And I think it is helpful if mum and dad can get on board in terms of strategies and how to sort of deal with it. But it sounds like a really classic kind of, the person is almost sort of lost in this anger and rage, and then afterwards can be sort of remorseful and feel you know, terrible, etc. And I think, you know, again, I'm not a clinician, but I think some of the resources that I can share with the group will probably sort of talk along the lines of, you know, just trying to make the environment safe while this is going on, and just sort of reassuring the person going, okay, I'm just going to, you know, step back a little bit so that you perhaps don't get hurt, but I'm here for you, and when when you're feeling a bit calmer, etc., then we'll talk. But not trying to talk during it too much and just, you know, just sort of leaving. It's also a little bit like the same kind of advice, I would guess, for something called tic attacks, where somebody's having a whole series of tics in very quick succession, and that's usually around anxiety as well. And so it's about providing a kind of supportive and calm, neutral environment while that's going on, so that the person can kind of come out of it. But I'm really happy to share anger and tic attack resources after as well. If you can share them with the audience, that would be great. And of course, Tourette's Action, Tourette's America have lots of resources on those topics as well. So definitely go and look up some of that.
That's great, thanks. And if you send me on the links that you have and any slides that you're willing to share, I can circulate them to everybody who's here this evening. Thanks. Ken, do you want to ask one more question?
Oh, just one. Again, I've been in this role with ADHD just over 5 years now, and I'm not a clinician, but I think I can nearly do diagnosis for people with ADHD at this stage. But again, I was watching Newsnight last night, and there was a Polish MEP on, and he was blinking a lot during his conversation. He said he has Tourette's, but I'm not a clinician. So the question came in there was, how often should sudden movements happen that we should suspect that a young individual has tic syndrome?
Mm-hmm. I mean, tics in their sort of purest form would be a repetitive movement or sound. So you're right, blinking, if it's more than a normal kind of blink rate and the person doesn't have an eye issue or something in their eye, and then there could be a blinking, and I'm doing this just to kind of demonstrate. And the same with sniffing as well. If someone's sort of repeatedly sniffing or throat clearing, but actually they don't have a cold or allergy, or there's no other sort of reason for it, then those can be tics. And when they sort of reach a level where they're starting to sort of interfere with, whether it's speech or life or doing tasks, etc., in your everyday living, and they're becoming difficult to manage, I think that is something to go and see a healthcare professional about. As long as, if they're not coming along with anything else, then it's probably just tics. But people should, go and seek reassurance and ask questions about that. But there are, many millions of people living with tics, and they manage fine. It's just part of who they are. They've accepted it. They're raising awareness. They're talking to others, etc. But where it becomes painful, or really the person is feeling that they need that extra help, and actually they want to find out, what is this, or they want to rule out something else, then that's where the healthcare professionals and the Tourette's Action website, Tourette's America, that's the place to go and look. Even if it's just tics, we talked about tics and tic disorders. It doesn't need to be Tourette's syndrome itself, but just tics in general. You can go and read and find out more about it as well, that way.
Okay. I believe we're almost out of time. Seonaid, thank you for working through so many of the questions coming from the audience this evening, and indeed thank you as well to Ken and Beth for working through so many. Our apologies if we haven't got to your question. However, I am pleased to say that there are opportunities, as Seonaid has just pointed out, for follow-up. I know, Seonaid, you're quite active in many respects. You've created the Behavioural Therapy for Tics Institute, and also, of course, your podcasts with the Association for Child and Adolescent Mental Health, and your other publications. So I'm sure there's many ways to follow up and interact with you. And of course, you've mentioned as well some international associations in Belgium, in New Zealand, in the United States, where people may wish to follow up. So thank you so much for joining us. It's been a pleasure to have you, Dr. Seonaid Anderson, on our Masterclass series. Just to highlight, of course, our next session coming up on March the 24th. It is March 24th, I hope, Beth. It's with Professor Sarah Rankin, and Sarah will be talking to us about support for staff and students in university and other workplace settings, in fact. So we'll be looking at how neurodivergent people can be supported in employment. And I know that's something which came up a little bit as well this evening. So I think on that note, we can sign out. But again, thank you everyone for joining us this evening, and have a lovely evening or afternoon, depending on where you are.
Thank you so much.
Thank you.
Thanks, everyone. Thanks. Bye.
Thank you.